Okay, welcome back, everyone. So, Jack, can you hear me okay?
Yeah, all good.
Yeah, awesome. All right, so very lucky to have Jack from RFDS talking. He's going to tell us a little bit about RFDS and the type of work they do. An extra big thank you for Jack. He's actually dialing in from Bali. So he's actually on holiday because he's filling in for someone else who's unable to make it. So massively appreciated, Jack, and really looking forward to hearing about RFDS.
Great.
So yeah, feel free to take it away.
Great. So I'm Jack Lewis. I'm one of the retrieval registrars for RFDS Southeastern. I started in August of last year. Thanks for having me on behalf of RFDS. It's a really nice opportunity to talk to the other retrieval services. I mean, sometimes it feels like we can, work close by or share a case together, but often we don't get a chance to talk specifically about how our different organizations work. So, really grateful to talk to you. I'm going to talk a bit about RFDS, particularly Southeastern, and how it's organized and how it works. I'm going to talk about the two bases, which are Broken Hill and Dubbo. And then I'm going to use a few cases just to try and illustrate the kind of work that we get. So let's go. So this will be the first. Oh, right. There we go. This will be the first and last historical slide. So this is the Reverend John Flynn, who established RFDS in 1928 after witnessing the struggles of the people of the bush and wanting to provide a mantle of safety. Interestingly, RFDS was established in 1928. The Broken Hill base has been running since 1936, so it really stretches right back to the beginnings of the organisation there. So within Australia, there are 6 RFDS sections. There's RFDS Queensland, RFDS Southeastern, which is New South Wales, and our bases are Dubbo and Broken Hill. RFDS Victoria, RFDS Tasmania, and they fly their planes up to Broken Hill to be serviced, so that's a long flight and a King Air. RFDS Central Ops, which is out of South Australia and Adelaide, and RFDS Western Australia are Western Ops. Although all centralised for branding and fundraising purposes, every section is different and they have their own medical and clinical framework. As an example, RFDS South Australia could regularly provide a GP for a flight if there was a patient that required a doctor. But if there was a critically unwell patient who needed retrieval, they would just provide the flight nurse and the pilot, and they would take the critical care doctor from MedStar that are co-located in Adelaide. RFDS Western Ops are notable for regularly flying from Perth to Broome and back, so big jobs for them. So this is RFDS Southeastern and our flight board. It was a GP-led service up until 8 years ago, and at that time they decided to move away from that model. And since then, they've employed critical care doctors to staff the retrieval arm of the organisation. The primary care arm is separate. So currently we have a staff which is made up of 4 FACEMs and 7 ED trainees, 3 FANS CARES and 5 anaesthetic trainees. There's a mixture of Australian and UK doctors, and we all live in Dubbo, and we rotate to Broken Hill for about a week every 4 to 6 weeks. All of the senior doctors work in Dubbo ED, either in the emergency department or the anaesthetic department, and the majority of the trainees are on 50-50 contracts as well. So there's quite a long relationship with Dubbo Hospital there, which works well. So our shifts are, the top here, this is Dubbo. So in Dubbo, there's a Dubbo day shift, Dubbo night shift, 7 till 7. And underneath, this is Broken Hill, where again, there's a Broken Hill day shift and night shift. There's a second plane in Broken Hill because it's quite busy there. There's often afternoon tasking, so they can do a pilot and nurse only job if required, or the doctor can do a later job without worrying about pilot hours. We also have a shift called an S4 shift, which I'll come to later in the cases. It'll make a lot more sense. But essentially, because the Broken Hill doctor covers such a massive area, and I think that area is as big as France. I mean, I'm English, so I'm blown away by the size of Australia, but it does seem a really large area to be on call for. If the Broken Hill doctor goes out on a flight, the S4 doctor will take over and manage cases virtually while they're flying, or in the situation where they're on a long retrieval, then the S4 doctor will man the phone for the clinics and the stations in case there's other unwell patients in the area. So our training package, so RFDS is really grateful that we're allowed to attend for the 1-week Sydney HEMS course. Following that, we do a week of fixed wing induction in Dubbo and a week of induction in Broken Hill and to the virtual care system there. We then have a period of buddy shifts before we're allowed to fly solo. In Dubbo, there's a new sim lab that was built maybe 3 years ago, and they employ a flight nurse educator there with the idea that the day doctor in Dubbo does a sim with the 2 flight nurses and the S4 doctor on a weekday. We do coffee and cases every week, and we do a sort of standard M&M every month. Between the trainees, we run an online training program where we all present virtually on a topic matched to the DIP Farm syllabus. And then for our downtime, we're all also assigned a project. So be it writing a guideline, I'm doing an electronic medical record act, other people are doing audits. So plenty to do. We'll talk a bit about the bases now. So this is Broken Hill. When I took the job, I was in East London and I looked at Broken Hill on the map and I was like, where am I going? What is this? But it is such a good place to work. It's such a cool little town. It's really beautiful. You can really get out into the surrounds around it, and the jobs that we get there are great. So being in Broken Hill has been a real highlight for me. It's been operating since 1936. So as I said, it stretches right back to the beginning of RFDS. And serving far western New South Wales. So this area, about as big as the UK or France since then. Co-located at the Broken Hill base is the primary care arm in the Clive Bishop Centre. And so there's GPs in the base and they fly out to remote outposts for scheduled day every week. And they'll take out a physio or a nurse or a mental health team with them. The job of the doctor in Broken Hill is quite big, so you can be tasked by ACC if there's someone unwell in Broken Hill Hospital for a standard unwell patient needs to be moved. Broken Hill has a ED and a CT scanner. It's got an ICU but can't keep ventilated patients. It's got dialysis machines, but they can't be used for some reason. And all the surgeons that fly out. So it's variable if you will be able to get a surgeon there or not. So it doesn't function particularly well to look after unwell people. And so a significant amount of our work is moving those people into hospital transfers of ventilated patients down to Adelaide. The other part of the job in Broken Hill is that you're on call for 6 nurse-led clinics and you're on call for remote stations as well. So this is sort of a virtual care part of the job, which is I think is quite unique to RFDS. So these are the clinics. So there's Menindee, Ivanhoe, Wilcannia, Whitecliffs, Wanaring and Tibooburra. And these are clinics that are staffed by quite a senior ED nurse with a sort of a booklet of presentations that they can treat on their own. And they'll do week on, week off, and they'll live in the clinic and be there 24 hours a day when they're required. And they'll manage all the simple things themselves. But if they're concerned or the patient's unwell, then they'll call you and you'll try and take over the case from there. So you can dial in on the overbed camera network. They can do iStats for you. So if it was a low risk chest pain, they could do some iStat troponins and send you an ECG. And you can manage that patient remotely and make a plan for their follow-up. But if the patient's more complex than that, if it's a high-risk chest pain or if they need some formal bloods or some imaging, then you need to arrange to have them to fly them out. So you would task the plane yourself, task the pilot and decide which hospital they go to, whether they just need Broken Hill or whether you need to go and get them and take them to Adelaide. And this part of the job gives you an awareness of the needs of the area and what's going on. And then you need to work out, well, if I send this person to Adelaide, the plane's going to be out for the remainder of the day. And so this person's going to have to wait in the clinic. And it allows you to think about resource management. And I've found this a really interesting part of the job. It's not something I'd ever done before. The overbed camera network is brilliant. As you can see the zoom, you can really look at what's going on. And they do say that you haven't done an RFDS properly until you've run an arrest from home in your dressing gown. So the other part of the work when you're in Broken Hill is that you're on call for stations. So on the same map here, just on the border with Queensland and South Australia, there's quite a number of really big stations, and they've all got RFDS medical chests. So you can be called by someone on the property at any time of day for anything ranging from an industrial accident or a quad bike rollover. And that's where we get this is where we get our primary work. So you're flying into the station on a dirt landing, and picking up your quad bike rollover, treating them and taking them to Adelaide. On the other side of the coin, this is also where you get called about a febrile 19-month-old on a Friday night. It's going to be a 10-hour drive for them to get anywhere, and the roads are wet, and their local clinic doesn't run until Thursday. So there's an opportunity to manage these people either via video on their phone, using what's in the RFDS medical chest. Maybe they need a dose of Dex, and you can review them in a couple of hours, review them in the next day, and make them a plan for the next couple of days. And it's really rewarding to be able to keep these people on their properties and let them avoid the 8-hour drive that's unnecessary. And they're really fun people to work with. So this is the Dubbo base. Things are a lot more conventional here in that you're tasked by ACC, so your phone rings and you go to base. It's been running since 1999 and providing Western New South Wales with retrievals. It's pretty standard inter-hospital transfers to a Sydney hospital. We do about 60 a month, but 60% of those are flight nurse only. So you're not flying every day when you're in Dubbo, which is why I like Broken Hill more. Also out of Dubbo, the dental arm of the service runs and the non-emergency transport side of the service runs. So that's probably enough of me talking about RFDS. I'm just going to talk through a few cases to try and show what the cases are like and how long everything takes, because I think the duration of some of the cases is going to be different, and the resources when we get to the scenes is very different also. Often you're the first on scene apart from the clinic nurse, and you have to use people from the local community to help you to look after the patients. So this is a call from Poon Carry Station when you're the Broken Hill day shift at 10 in the morning. There's a 40-year-old man who's been charged by a bull after trying to ride the bull, because people still do that in far western New South Wales. He's got abdominal pain and chest pain and he can't breathe. There's no observations because they don't have any equipment to do any observations, but he's crying in pain. So you ask them to get 10 milligrams of endone out of the medical chest. You task yourself as a P1 and you're ready to leave in 45 minutes. And you hand the case over to the S4 doctor, who calls the station and tries to virtually manage the case while you're in the air. This picture is Poon Carry Station from above. As you can see, there's not a lot there. And as you land, this is the dirt landing strip at Poon Carry Station, the ripped windsock and a few farmed buildings. So you get the farmhands to come and help you. They come across to the plane with their ute and you load your stretcher onto the ute, and they drive you over to the farm building where you found the patient lay on the kitchen table. Airways patent, sats are 89% on air with a raised respiratory rate, a heart rate of 110 with a good radial, and some bruising on the abdomen and left chest wall. And when you do an EFAS, there's no lung sliding on the left side. So appropriately, you do a kit dump and you set up for a surgical chest drain and insert that on the left side and then relieve the patient's symptoms. The rest of your fast scan's negative. You use ketamine for analgesia, put on a pelvic bounder, and again, use the farmhands to help you get the patient onto the back of the ute, and you're ready to depart 2 hours later to take them down to Adelaide. If you're leaving at 10 to 3, you're not getting to Adelaide until 10 to 5. And you deliver him well to the ED. He's had some ketamine during the flight, and they find 4 left-sided rib fractures and lung contusions on the CT. This is Rory. This was Rory's job. Rory is a UK anaesthetic trainee. He'd never managed trauma outside of being the airway person in a trauma team in a tertiary hospital until he started with RFDS. So this was a great job for him. I'm a bit jealous. So the next case is a call from Inaminka Station when you're the Broken Hill day doctor. There's a 55-year-old farm worker there who's been stung by a bee and has developed some lip and eye swelling and feels wheezy.
Again, they can't do any observations, but they think is pale. They have a medical chest and they're just going to go and try and find it. So again, you task as a P1 and you're ready to leave in 45 minutes. You hand the case over to the S4 doctor who phones up the station. They find the medical chest. There's no adrenaline in it, but they manage to realize it's in the fridge. And so the S4 doctor talks the station owner through cracking the adrenaline, drawing it up with a needle, and administering it to the patient in their lateral thigh. By the time you get to the patient, they're doing a lot better and their symptoms are resolving, the lip swelling settling down, and you fly them out to Broken Hill ED for some observation overnight and to make sure they have an EpiPen from now on. That's the kind of thing you can manage with a medical chest and with some coaching. So this job is you're the double day doctor and you're retasked to a road job for a gentleman who's 72 and has presented to Gallagher Bone Clinic after his left hand has gone into a bandsaw, and he's presented there with some arterial bleeding and a systolic of 70. There's an AIN in Gallagher Bone Clinic who can not get access but can give him some Panadol. So you task as a P1, you put your stuff from the plane into the retrieval ambulance, take some TXA and some ketamine and add 2 units of blood and start to drive towards Gallagher Bone. In the meantime, a local ICP attends the clinic, puts the tactical tourniquet on the gentleman and gets some IV access and runs some saline, and then starts to drive towards you, leaving Dubbo, and you meet each other on the road about 50 minutes later. By this time, it's about midday, and you find the patient with his own airway, SATs 92% on air with a poor trace, a heart rate of 110, and they're struggling to get a blood pressure at all, but he does have peripheral pulses. The tactical tourniquet didn't control the bleeding, so they've put a blood pressure cuff just proximal to that, which has done the trick, and he's got the saline running. He's in a lot of pain from the tourniquet, so you give him some ketamine with a new IVC that you've put in, give him the TXA and start the blood, and start driving towards Dubbo. Have a quick chat with APC about whether this man needs vascular, and the decision is to move him to Dubbo and review it when you get there. So on the journey, it's about 45 minutes, you give him the 2 units of blood. When you get to Dubbo ED, his first systolic is 105. The trauma team are ready and the surgeons take him to theatre to look at his wound, and they're able to repair his artery in theatre, and he makes a good recovery. So this case is a call from Wilcannia. So Wilcannia is a nurse-only clinic. It's a couple of hours drive from Broken Hill. It's quite a busy township and there's lots going on there. So this is a call at 6 in the morning about a 29-year-old male who's been brought in by police. He's agitated and in handcuffs. He's known to have schizophrenia and has presented several times before. They think he used drugs a week ago, but not recently. They can't get any observations on him, and he's refusing any oral medication. So you task as a P1 to go and get him. You ask them to give him 10 milligrams of droperidol IM, and you talk to the S4 and get them to sign into the video camera and talk to the nurses while you're in the air, because you're going to be 50 minutes before you get there. When you arrive at Wilcannia, he's had a further 10 milligrams of droperidol IM from the S4 doctor, but it hasn't done the trick. He's still really agitated. His airway is his own, his heart rate's 110, his GCS is 14. There's no fevers, there's no suggestion that this is infection or sepsis or toxidrome, and there's no trauma or head injury. This appears to be a pure mental health case. So you're with the patient at 10 to 8 in Wilcannia. You realise you need to get control. So with the police's help, you insert an IV cannula and you give 1 milligram per kilogram of ketamine IV. This allows you to get your full monitoring on, your end-tidal CO2, get the patient onto your stretcher and do an initial eye stat, which is all normal and all reassuring. You decide this man needs more than Broken Hill can offer, so you change your destination to Orange because you need some acute mental health input. The pilot does the flight plan and you load him onto the plane. In this process, he needs another 0.5 milligram per kilogram of ketamine IV, and so because of that, you start a ketamine infusion running at 1 milligram per kilogram per hour, and you run this during the flight to Orange, which is uneventful. You stop the ketamine infusion as you're arriving into Orange, aiming to deliver an awake patient to Orange ED. So this is an example of a primary mental health transfer.
Wilcannia is a small town. While this man's in the clinic, the nurse can't leave. So she's, if he's there for 13 hours, she's there for 13 hours as well. And it takes up a lot of resources in the town. There's only 2 policemen in Wilcannia, and they're both in the clinic while this man's there. So when we get calls like this from these clinics, we really need to respond and help these people, and that's a big part of our role. We also do sort of secondary mental health transfers. So someone who's presented to Broken Hill ED and been assessed overnight and has perhaps had some droperidol and some oral diazepam and is settled, then we'll move them from Broken Hill perhaps to Orange or Bloomfield in the morning. Because the inside of a plane is so cramped, I mean, I know you guys use King Airs too. We're very restricted in how we move these people and how cautious we have to be. So they're all risk scored, and this is the risk score that we use. It's quite subjective in a way, and it focuses on what's been happening with the patient in the couple of days before they present. And it's very easy to score a high score, but I think the idea is that no one's under triaged. So to be low risk and to be a nurse-only job, you really cannot have any history of mental health, history of substance use, and that's because once you're up in the air, it would be really difficult to control someone. So anyone who's medium to high risk must have a flight nurse and a doctor on the flight, and you must have IV access and be ready to give some sedation if you've not already got some running. These are our sedation guidelines that we use. So we would gauge their mental health risk against their anesthetic risk, rapidly look for an alternate cause of their presentation. The ketamine infusion protocol can only be used on pure mental health. If there's any suggestion of sepsis or a toxidrome or any other cause, then the patient would be for intubation and ventilation and transfer. You must have full monitoring and end-tidal CO2, just as if you were doing a procedural sedation in a resus bay. We would start with the lightest sedation required, be that oral diazepam or IM droperidol. But if the patient is agitated and we don't have control, then we'd use IV or IM ketamine to gain control. And if further boluses were required, then we would start a ketamine infusion at about 1 milligram per kilogram IV and run that for the duration of the flight. The evidence for this comes from some case series done by Min Lekong and Tim Lurenberg, who work for RFDS Queensland. They're not huge case series, they're sort of 20 to 30 patients each. And the adverse effects really are sort of hypertension and some transient hypoxia that resolve without interventions. I won't talk through these, but I'll leave them in the slides for you to look at yourselves. So another case now to finish with. This is a call from the nurse in Tippabura. A 35-year-old man there has called after a bull calf ran into his right knee earlier that day. And he's developed a lot of knee pain through the day and presented to the clinic. Viv's gone to get him and she's worried about him. So you analgesia him straight off with some Panadol, NSAID and some endo and try to examine him via the camera a couple of times, talking Viv through the examination of the knee. But this man just can't bend his knee, can't straight leg raise. It's really swollen and you're concerned about his increasing pain. So you task as a P2 to go and get him and you send the doctor because you're worried about his pain. And while you're in the air, the S4 takes over the case. So you called at 6, you were ready to leave at 8. And you were with the patient for 9:30. In that time, the S4 has tried some more analgesia, but isn't really getting there. And when you find the patient, he's still in a lot of pain. His right knee is really swollen. He can't really move it at all. The R pulse is present. You do an ultrasound of the tibia, which shows a break in the cortex. And just getting him onto the stretcher, which goes in the back of the troopy there, you're needing 15 of morphine and starting to use the ketamine just to control his pain. So you're realizing that this man needs more than Broken Hill ED, and so you ask your pilot to change the destination to Adelaide because you think he'll need orthopedics for sure and maybe vascular. So you're ready to leave with the patient at 11:10. It takes a lot of time to get, it's just you and the clinic nurse, so there's no spare hands. It's hard loading people into the back of a troopy and on the troopy stretcher and getting them on the plane, so everything takes a bit longer. During the flight, this man needs 200 of fentanyl and 40 of ketamine. His pulses are getting weak by the time he's getting to Adelaide ED. and CT shows that he's developing compartment syndrome, and they take him to theatre. I think this case shows the complexities of managing people via the video camera and getting someone else to do the examination, and it forces you in to make decisions about tasking planes and moving people. Because of delays in Adelaide, the team were actually stuck in Adelaide for the duration of the next shift as the pilot ran out of hours and needed to rest before they could leave, which is actually a lot more fun than it sounds most of the time. Thank you for listening to me. I've had a really great time working for RFDS this year, and I've extended to stay on for longer. I've learned a lot of my clinical skills, but also the human factors and resource management side of the job, I think, is something that's going to help me in the future. I'm hoping that I'm going to star in the series 2 of the RFDS TV show, which is filmed in Broken Hill. Any questions?
Yeah, awesome, Jack. Thanks so much. That was a really awesome talk. And yeah, just cover it. It's just interesting looking even just at your times, just the kind of epic kind of clocking some serious hours on each mission. So I can imagine getting tasked just before you're about to hand over means a whole different thing to you guys than maybe some of our jobs. If people just want to pop any questions in the chat, I can fire them through if anyone's got here. Thanks very much for talking about the mental health side of things. That was something I was chatting to Rob with when we were organising this was, what things can we kind of learn from other services? And I think it's really interesting looking at those sort of, I think you called them primary mental health transfers. And it's interesting just seeing that sort of ketamine sedation side of things, because in many ways, to me, it feels easier in a way to, from a clinical point of view, actually just to intubate them, bang, they're there, done. I think, I imagine it takes quite a lot of finessing to, essentially run a very prolonged procedural sort of sedation. And very interesting case series that we'll check out. Has anyone in the room got any questions? I'll pass the mic around.
Obviously, it allows you to avoid the intubation and ventilation of these patients. So hopefully you're avoiding an unnecessary ICU stay for them.
Yeah.
Awesome. Thanks for that. Hang on, I'll turn it on.
Oh, sorry, I'll set you up. Sorry, there we go. Thanks, Carl.
How's that sounds better, doesn't it? Great talk, thanks for that. So I guess these are unique locales in Australia, so Western Australia, South Australia, far western New South Wales, Queensland. The distances are massive, and we've seen a couple of cases there where even with a very rapid tasking, you're not at the patient for several hours and not at the destination hospital for 8 hours plus after the time of the call. And I wonder, has it ever been required that someone with something that sounds just desperately bad, you just accept that a private vehicle and take their chances might be a way forward, and how do you make that sort of difficult decision?
No, definitely. I think something that you talk through initially when you're tasking is how long would it take you if you started driving. These people often know where the nearest airstrip is and where they can get to. The roads aren't always serviceable in these locations, so there are times when it's just not safe for them to drive anywhere. And there are other times where they will say, I'll meet you at Bollard's Lagoon, or I'll meet you somewhere else. And the pilots are very savvy. A lot of them have worked for RFDS for a long time, so they know the individual options of where you can go. And then you can try and plan things based on what's going to be the quickest way. But yeah, you're right. Things take a lot longer for RFDS to get to them. And in a way that, they've survived their initial injury by the time we've got to them in many circumstances.
Yeah, awesome. Thanks very much, Jack. We've still got another sort of maybe 5 to 10 minutes or so of any discussion points or questions. If anyone's got anything else to go over. I was just wondering, just in terms, you're covering huge sorts of areas. You mentioned being both at the Dubbo and sort of Broken Hill base. Do you find that everyone, the sort of doctors there, do they tend to sort of base themselves? Do you sort of tend to live at one base and sort of commute to another, or do sort of a FIFO or sort of rolling roster? How does that work?
Yeah, so RFDS are great to work for. They give us all a house in Dubbo, so we all live in Dubbo, and then they fly us out to Broken Hill for our shifts there. So usually they'll group your shifts together, and you'll go out to Broken Hill for 5 to 10 days, about every 4 to 6 weeks. And so a lot of us are 50-50 in ED or anesthetics, so we'll do two weeks ED, and then you'll go to Broken Hill for your shifts one time, and then you come back and do 2 weeks ED, and then you might do 2 weeks in Dubbo. It's something that when I looked at the job from the outside, I wondered how it was going to go. I've got a family and 2 little boys, but I love going out to Broken Hill. The jobs there are brilliant, and it's great to feel like you're immersed in the work when you're there the whole time you're there, and then come home and move away from that and sort of have a break.
Yeah, totally. Awesome. Yeah, no, I think it's very, very impressive. Any other questions for anyone in the room, or any thoughts from a fixed wing perspective?
I was wondering, hi, it's Alex. I was just wondering if there's any kind of, if you have a structure, you were saying like the problem solving aspect in terms of piecing the puzzle together with where assets are and where the team is. Do you have a structure for how you approach that, or is it just kind of, it's so varied every time that you
It is quite varied. You know, I was quite overwhelmed by it when I initially started, and I just used to have a map of the area on my desk, and I'd write down what was happening in each place. And obviously, you know the planes, and you know that you've got 2 pilots and 2 nurses. And I suppose I just picked it up through experience. We have a really good clinical support network as well. So in your initial days on the job, you have to call everything through and talk every tasking through. And it's a bit of a step, or it was a bit of a step for me to fly somebody out just for an X-ray and some bloods. You know, initially I sort of almost thought, is this the right thing to do? Should I be really tasking a pilot and a plane to get someone an X-ray? But there's just nothing around, and you know, there's no other way. And as the last case shows, you know, if I'd left that gentleman till the next day to get an X-ray, you know, he would have been in dire straits by the morning. So I think it's a tricky thing to learn to manage, but we're well supported initially, and then after that, it's you know, it's not being like a mini state retrieval consultant, but it's sort of a taste of that, and it's just been a really good experience for me in terms of managing resources and, you know, thinking about managing a department in the future.
Yeah, awesome. No, it sounds a definitely a different aspect to the job. We just got one of our registrars just asking, when you're kind of in that when you're in that role, how do you sort of interact with other services or sort of statewide coordination of retrieval? You know, to make sure that you're sort of tasking, and because it seems like you're doing a lot of self-tasking. Is that correct?
Yeah. So you phone state retrieval to tell them that you're tasking the plane, and you know, often you'll just talk to one of the coordinators there and tell them that you're doing it. But if you have any questions about the case, then you can ask to be put through to the state retrieval consultant just to run it by them as well. We also have our own sort of 24-hour call system where we can call our senior consultant to talk through cases. And initially you'd call them for every tasking, but then as you're more independent, you just task on your own.